everybody. I'm Dr. Carmen Puliafito, and I'd like to welcome back to Retina Synthesis Dr. Tom Ciulla. Tom, how are you?
I'm great, Carmen. Thank you so much for having me.
Tom is Chief Medical Officer and Chief Development Officer at Clearside Biomedical. And Clearside released recently some very exciting results using suprachoroidal delivery with a tyrosinase kinase inhibitor for treatment of Neovascular AMD, with excellent safety results and some very interesting efficacy data. And we'd like to talk about that today.
Well, again, Carmen, thanks for having me. Can I share some slides?
Yes.
All right. All right. Can you see the presentation mode?
Looks excellent.
Good. Okay, great. So let me talk a little bit about some of the basic properties of suprachoroidal delivery first, for those who may not be as familiar with suprachoroidal delivery. So what we're doing is we inject at the pars plana with the microneedle, and you can see how the injectate flows posteriorly and circumferentially. And that allows us to target the chorioretinal tissues with drug and then compartmentalize the drug to that area, minimizing exposure to the anterior segment. This is actually a clinical trial patient undergoing an injection. Other than the drape, it's pretty standard, very similar to an intravitreal injection. You can see a sterile lid speculum, there's betadine pooling in the eye, the plunger is being depressed. So very straightforward. Obviously, the patient's not moving, there's not any obvious signs of distress or pain. And what we can do here with small molecule suspensions is achieve prolonged durability. So here we show our standard rabbit pharmacokinetic study. And you can see we've assessed triamcinolone acetonide, which is our first asset that was approved, Xipere. We've assessed axitinib, which is the asset we'll talk about momentarily, as well as a complement inhibitor and plasma kallikrein inhibitor. In all cases, we get prolonged durability out to the duration of the experiment to 90 days. And what drives durability is the particle size in these suspensions, as well as the relative insolubility. Essentially, we inject into the suprachoroidal space. The injectate flows posteriorly and circumferentially. The aqueous phase is absorbed fairly quickly, and that leaves all these drug particles in the suprachoroidal space, and drug essentially slowly dissolves from these particles into the adjacent tissues.
So is the suspension proprietary?
It is. It's not. It's a fairly basic suspension, but again, what drives the durability is the particle size and the relative insolubility. For triamcinolone acetonide, our first asset, Xipere, we have a very specific particle size distribution. We add surfactant. This has all been tested for the microinjector. The injecting physician needs to feel for loss of resistance. So we need to maximize that tactile feedback. Once they have loss of resistance, they know they're in the suprachoroidal space and they can advance the plunger. So there are some key aspects of the formulation, including particle size distribution and surfactant. These are some images that we've published in the past showing opening of the suprachoroidal space. In the upper image is acute opening of the suprachoroidal space anteriorly. You can see on the OCT, denoted by the blue arrow, how the space is opened anteriorly. And then posteriorly, the space is opened a small amount as well. Again, these have all been published. What drives the injectate posteriorly is a pressure gradient. There's a natural pressure gradient where the intraocular pressure is greater than the anterior suprachoroidal space pressure, which in turn is greater than the posterior suprachoroidal space pressure. So the injectate just flows naturally down this pressure gradient towards the macula. So that's a little bit about, the basics of suprachoroidal delivery. I'll talk about CLS-AX next. This is a very high-level overview of what we found. Sorry, I'm going to go to the next slide here. This is a very high-level overview of what we found with CLS-AX. This is a tyrosine kinase inhibitor. We found a pristine safety profile. We've had excellent durability in the parent study, OASIS, out to 3 months. There was a 73% reduction in treatment burden. And the extension study, which includes most of the patients in the parent study, out to 6 months with interim data, we had a greater than 90% reduction in treatment burden. And then we've seen biologic effect with respect to stable visual acuity, stable central subfield thickness, and I have a few OCT cases I can share. Just to back up a little bit, the idea behind this is that tyrosine kinase inhibitors are pan-VEGF inhibitors. So you can see on this cartoon on the right that Eylea, Lucentis, and Avastin work essentially by binding VEGF-A. However, when you bind VEGF-A, you have upregulation of C and D, and C and D can stimulate the VEGF-2 receptor, which mediates angiogenesis. With the tyrosine kinase inhibitor, we're basically switching off all the receptors, and so we can circumvent this problem and potentially bypass a ceiling of efficacy. We've chosen axitinib because it's one of the most highly potent tyrosine kinase inhibitors that's been tested in ophthalmology, and it has excellent ocular cell biocompatibility compared to other TKIs, so it may have some intrinsic safety benefits. When we inject it suprachoroidally, you can see on the left in our standard rabbit model, we compare suprachoroidal delivery with intravitreal delivery, and in that uppermost orange box, we get 11 times the levels in the retina, RPE, and choroid when we go suprachoroidally versus intravitreally. And conversely, we get 3/1000ths the levels when we go suprachoroidally versus intravitreally in the vitreous. And in the aqueous and plasma, we're at or below the limit of detection. So we have a really great ability to target the affected chororetinal tissues, which may provide some efficacy benefits and compartmentalize away from the front of the eye for some potential safety benefits. On the right is another rabbit study where we look at durability, and you can see out to day 182, basically in the suprachoroidal space in dark blue, and in the retina in light blue, we have levels that are several log orders higher than the IC50 for the VEGF receptor 2. So this gives us confidence that we can achieve durability in the range of 6 months. And then the other interesting thing about this bar graph on the right is that it also shows the compartmentalization effect. So the highest levels are in the dark blue in the suprachoroidal space, basically, and then next in the retina and lower levels in the vitreous. So the basic premise is that we're marrying a very highly potent tyrosine kinase inhibitor with the potential benefits of suprachoroidal delivery with respect to targeting, compartmentalization, and durability. So the trial design was a single injection, open label study. All patients had active disease at screening. They were all treatment experienced, but they had persistent activity at screening confirmed by a reading center. They got aflibercept at screening. A month later, they get CLS-AX, and then they're followed out essentially to 6 months when we include the extension study. And we get this question all the time. Why do we design the study to enroll these heavily anti-VEGF treatment experienced wet AMD patients? Well, we wanted to do this because we wanted to minimize the risk of a false signal of biologic effect. In other words, if we have treatment experienced patients and they're inactive, we don't know how needy they were for treatment. In this case, they're treatment experienced patients who are active on screening confirmed by a reading center, so we know they need persistent treatment. And this allows us to potentially de-risk future clinical studies. So again, the safety profile was pristine. There were no SAEs, there were no treatment emergent adverse events related to the study treatment, no dose-limiting toxicities, no adverse events related to inflammation, vasculitis, or vascular occlusion, no floaters, detachment, endophthalmitis, or IOP events. In terms of the durability, we saw excellent treatment burden reduction. When we look at the average monthly injections before CLS-AX administration versus after, and when we look at basically all therapies versus per protocol criteria rescue therapies, there was a 73 to 100% reduction in treatment burden in cohorts 3 and 4, the higher dose ones. This is a swim lane plot of treatments before and during the study. The column of red dots represents the aflibercept injection at screening. Everything to the left of that is their 6-month prior treatment history. The green column of dots is the CLS-AX injection administered suprachoroidally. And then we can see all the visits. And again, the 6-month data is interim data. So this is the follow-up through October 27th. And what you see here in cohorts 3 and 4, the higher doses, the 0.5 and 1 milligram dose, to month 4, 8 of 10 patients who made it to month 4 made it without requiring additional therapy. 7 of 8 made it to month 5 without requiring additional therapy. and 3 of 4 made it to month 6 without requiring additional therapy. So we think this really demonstrates the potential durability of this treatment. What I just showed you were all the therapies, and these are the additional therapies per protocol criteria. So it's an even better profile when we look at the patients who were treated per protocol criteria. When we look at the supplemental anti-VEGF injection-free rate up to each visit in cohorts 3 and 4, again, we see a really excellent profile. This really demonstrates the potential for durability with this asset. Some more information on treatment burden reduction, this time out to 6 months. And basically, we had a 90 to 100% reduction in treatment burden in cohorts 3 and 4. When we look at best corrected visual acuity change from screening, we can see it's quite stable. At month 6, because this is interim data, the sample size decreases meaningfully. We're down to 4 patients on the left and 3 patients on the right that have made it to month 6. And you can see that the error bars cross the 0, no change line. So stable visual acuity overall. When we look at CST, again, these are smaller sample sizes as we get out, and there's more variability. But if we look at the overall mean, the CST appears to be quite stable. And then finally, I want to follow up with a with a case. And Carmen, you're the father of OCTs, so I think you'll like this case. This is cohort 3, subject 2. This patient had 89 prior anti-VEGF injections. So you can see in the upper left, they show up at screening with the best corrected visual acuity of 75, or about 20 over 32, a CST of 265. You can see there's a fibrovascular PED, there's subfoveal fluid. They receive aflibercept at screening, and 1 over to the right at baseline. We can see that the subfoveal fluid improves, but actually persists to some extent. The visual acuity stable at 73. At this baseline visit, they receive CLS-AX suprachoroidally, and we can see that they're maybe a tiny bit worse at month 1. They're the same at month 2. But if we look at the lower left at month 3, the subfoveal fluid begins to improve meaningfully. The visual acuity is stable at 75 letters. And at month 4, the subfoveal fluid essentially resolves. Visual acuity stable at 74. And what's really interesting, the OCT looks better 4 months after CLS-AX than 1 month after aflibercept. And that's immediately above it at baseline. And then at month 5, the fluid begins to return, and at month 6, they required additional therapy. But I think this is a really nice example of a biologic effect in a treatment-experienced anti-VEGF subresponder. Any comments on that? You're the OCT expert. Do you like that case?
Well, I think it's what's impressive about it is it really shows that the TKI is working, which has been really the question. The powerful efficacy of the TKIs has been questioned, but here it shows that it really is working.
Yeah, I thought so too. I have more cases, but this is kind of a shortened presentation, but I just really wanted to hit the highlights for you and for the listeners. And I'll just summarize here, and happy to discuss further. But I wanted to summarize what we found in the parent study, the 3-month OASIS study, and in the interim analysis of the extension study. So again, with respect to safety, we found an excellent safety profile at all doses and time points. And we feel that this has some competitive advantages because axitinib is a well-characterized small molecule. It's already been approved for renal cell carcinoma. And being a small molecule is less risk for inflammation than a novel biologic agent. There's no need for an operating room setting because this administration suprachoroidally is office-based. There's no risk of any implant migration. There's no risk of, very low risk of any vitreous floaters because we're injecting behind the retina. And the suprachoroidal injection procedure has been commercially accepted by the retina community because we've already had launch of XIPERE. In terms of durability, we saw great signs of durability, a greater than 73% reduction in the parent study, and a greater than 90% reduction from the extension study interim data. And we think that this level of durability compares favorably to other current and investigational intravitreally injected agents. And we feel that this has a durability effect that actually compares quite favorably to other extended release TKI formulations that are currently being assessed. And finally, with respect to biologic effect, we saw a stable BCVA, CST, and I have other cases that I presented on a webcast a few weeks ago. But we feel that having really the most potent tyrosine kinase inhibitor in wet AMD trials, it's quite differentiated from focused VEGF-A blockade. And we think that targeting the affected chorioretinal tissues may further leverage the efficacy because we're going suprachoroidally. So I'm happy to stop there and discuss. There's a lot of aspects of this that we can discuss.
What's the phase 2 trial going to be like? Are you in a position to comment about the study design?
We're still evaluating, but I wanted to go back to this slide. So just to emphasize, we enrolled heavily anti-VEGF treatment experienced wet AMD patients. On average, they had, depending on which of the 4 cohorts, but in the mid 20 prior injections. And again, they all had active disease at screening. And so we basically chose the most difficult patients to treat. And we're convinced that we see a biologic effect. And I think starting with this most difficult patient population, this gives us a lot of opportunity. So we could continue with this patient population. We could look at treatment naive patients, and potentially do induction treatment and then maintenance with our therapy. We could look at lightly treatment experienced patients who have been diagnosed within the last 9 months, for example, and have been injected, 2 or 3 times in the past, and that show a good response. So these are all the different populations that have been assessed in various trials. And I think they're all open to us. We're also considering other indications like diabetic retinopathy. So we're assessing all of our options right now. And we plan to start a phase 2B trial in the first quarter of next year.
So how do you imagine this agent would be used in the real world? This is speculative, of course.
Well, I think other TKI companies are positioning their TKIs as maintenance therapy. And I think because we've seen these signals in this subresponder population, we think, again, there's potential for this to be used in maybe treatment naive patients, maybe treatment experienced patients with inactive disease that we want to maintain, or maybe in subresponders. So I think there's a lot of potential, and we're still exploring that. But we're really excited about it. I think marrying a very potent TKI with the potential benefits of suprachoroidal delivery gives us lots of options.
Well, this has been a very exciting discussion, Tom. Thanks for
having me. Yeah, thanks for having me very much.